Welcome to this PCI webinar dedicated to left main bifurcation PCI, proper use of imaging and functional guidance. We are here in the Cath Lab of the Cardiovascular Center Aalst. My name is Emanuele Barbato, and I have the pleasure to share this case with my colleague and friend Gabor Toth from the University of Graz, from Eugenio Colaioli here, our clinical research fellow, Bernard de Bruyne, another colleague of the team, who will shortly join us from the Cath Lab. Before starting and presenting you the case we are all doing together this afternoon, I just would like to give you a few words of explanation regarding the format of this webinar. This is the second module of a series of 4 webinars. Today will be dedicated to a practical live demonstration here in the Cath Lab. This is an interactive webinar. Therefore, we really expect you to give a large contribution in terms of questions. There is also a very easy and quick way to interact with us simply by clicking on 4 options, whether you agree, you disagree with us, whether you like what we are doing, whether something we said or we explained is not clear. So please use this tool. Perhaps it's the time now to move to the slide. So the key objective of our webinar today, first of all, to demonstrate how to apply functional assessment in left main disease. We also try to demonstrate how to perform PCI optimization with OCT guidance in a very challenging lesion setting, as you will see in a while. And finally, we will also touch upon very briefly on how to deal with downstream stenosis in patients with left main disease. Perhaps it's now time to introduce the case, Eugenio.
Okay, we have a 49-year-old male patient presenting with stable angina. He has several cardiovascular risk factors and is an active man. In 2011, he had an out-of-hospital cardiac arrest and was treated with a PCI of the proximal left anterior descending artery. He is now well treated in medical therapy, as you can see from the list of medications. The laboratory investigation was unremarkable. The ECG showed a sinus bradycardia and there are no alterations at all. The LV angiography displayed a preserved LV functions. The right coronary artery presents a tight stenosis in the mid-segment. And what caught our attention of the left coronary system is a moderate stenosis of the mid-LAD and a tapering of the left main. Which we can better appreciate in the spider projection, where the dimension of the left main is comparable of 6 French diagnostic catheter.
Thank you very much, Eugenio. You nicely presented us with the case we have to deal with this afternoon. It is indeed a challenging case, Gabor. We have a patient with multivessel disease. There is indeed a tight stenosis of the mid-segment of the right coronary artery. In the left coronary artery, we have an intermediate stenosis, if we may call it like this, of the mid-segment of the LAD in this equivocal lesion of the left main. As it usually happens, these patients do not come with one lesion alone, but they present with different kind of lesions. What we have already performed previous time, at the time of the coronary angiography, was the PCI of this right coronary artery. We started intending to implant one long stent in the proximal lesion, but due to some sort of fragility of the vessel wall, there was some edge dissection that pushed the operator to implant additional 2 drug-eluting stents. And this was the final angiographic result. What we have to deal with now is this disease of the left main. Any comment at this stage from your side?
Well, in general, assessing left main simply based on the angiogram, it's always really challenging. You don't have good reference diameters. It's difficult to find a good projection without foreshortening and clear view on the bifurcation. So my feeling about left main in general, that taking a decision just based on the angiogram, it's difficult and even questionable.
Yeah, this is indeed a case where I would feel comfortable to perform some additional evaluation. And let me just make sure that our colleagues from home are following us. Would you agree with the statement that at this stage we need more information on this case? If yes, please push on agree. So while our colleagues are looking at the angio carefully and they are making up their mind, we see actually the column really going up. We have a massive feedback here. Majority, if not all of the colleagues agree that we should do additional evaluation of this left main. Now, let me ask you next step. First, do you agree with them? We need
Absolutely.
to do so.
So
Absolutely
taking a
agree.
decision just based on angiogram, I think it's not reliable in this case.
Okay, then next question, but before posing the question to you, let me ask the colleagues, would be invasive functional assessment your first choice in terms of additional diagnostic assessment? Please push on agree if you agree from home that we should do invasive functional assessment to obtain more information of this left main. And again, while I give the time to the colleague to answer this question, we see the answer. What is your opinion about?
Well, in this particular case, doing functional assessment is really important. First of all, this patient has already experienced an anterior infarction in the past, so it can be completely can have an impact on the functional importance of this we can call moderate left main stenosis. So I would personally definitely approach this lesion first with functional assessment.
So that would be your first choice, and indeed this would be the first choice also from the majority of our colleagues, but I saw that quite a sizable portion of the colleagues from home do not have the same kind of opinion. So therefore, let me ask the last question for this first part of the webinar. Who among you would rather prefer to start as a first option intravascular imaging as a tool to assess this left main? Please push on agree if you like this option. Yes, and actually the rate of colleagues who disagreed at my first question are picking up now. So you see there is some mixed feeling. There is indeed a majority of colleagues who would prefer for invasive functional assessment as first option, but there is also a number of colleagues who would prefer to do imaging in this case. Any opinion about that?
So we have good data that invasive imaging correlates very well with functional importance in the left main. Most probably this is the location where we have a really nice correlation between the invasive imaging and the functional importance. In addition, imaging can later on during the procedure eventually even help to optimize the procedure to guide the PCI. So I'm convinced that imaging is a valid tool for assessing this left main.
Okay, so I see already that there are questions coming from the colleagues. No worries, we will try to address all the questions by the end of the webinars. Just allow us to fit your questions within the flow of the discussion. So any of your questions is very valuable. But let me check how far is Bernard in the Cat Lab. Bernard, do you hear us?
Hello, Emanuele.
Yes.
Yes, welcome to the Cat Lab. Thank you, Emanuele, and thank you, Gabor, for joining us. I'm working here with Katja and Eddie, and we were listening to you, and what we did in the meantime is to repeat the shots like we always do. We first checked the right coronary artery. Maybe you can show that there.
Yeah, perhaps, yes, Bernard, give us a minute. Yes. We will join you there, so you take over and you walk us through your angios.
Okay, so you see now the right coronary artery, and you see that the stents are nicely deployed. Emanuele told you that we had a very short lesion, and actually we had to put approximately 6 centimeters of metal because we each time produced a dissection distally, which was an almost occlusive dissection each time. So this has to be taken into account when we start thinking of putting stents in the left system, because probably the structure of the coronary artery is very similar on the left. Now go to the left, Katja, and in the left you will see what you have seen already, a kind of smallish left main. I cannot say that there is a focal stenosis, and you see that also in the mid-LAD there is something which is irregular. I would say by visual estimate 40%, and the left main I would say, yeah, well, it must be 50% or 40-50%, so between 30 and 70%. Next, Katja. One, I don't think the previous one was very useful. Ah, yes, we see the left main even better. Yes, we see that the ostial left main is diseased. We see that the whole body of the left main is diseased. That's important information. You see that the ostium of the circumflex does not look to be diseased, and we see that the mid-LAD is diseased, but again, angiographically, it doesn't look like a terrible stenosis. Then you see very well the stent in the proximal LAD, which was placed in Greece a couple of years ago. Next. And there we see again the left main in the spider view. You see, from here, to be honest, if you are a little bit sloppy, you would say, well, there is a little bit wedging with the diagnostic catheter, but nothing to write home about, and you would neglect that. Fortunately, I would say we had a serious wedging, so our eye was caught by what was seen on the pressures, and we went a little bit further. And this is probably what we are going to do now. Is that okay for you if we proceed, Emanuele? Fantastic.
So we can already quickly address one of the questions asking us, one of the colleagues who asked us whether this stenosis in the left main was already present back in 2011. But as you already explained, previous procedures were performed in Greece, so we don't have notion of this kind of information.
No, we have no details about this procedure. This was done 7 years ago. We don't know which type, which dimension of the stent. We see the stent in the proximal LAD. We cannot tell whether the left main was diseased. We cannot tell you either whether there was something on the right, but the patient doesn't know anything about that. So, what we had in mind, and again, I will let the lead to Emanuele to discuss the strategy in this patient, but what we had in mind is to first assess the severity of this left main, whether or not this is really a significant left main, whether or not we have to treat this, to assess maybe the mid-LAD, and then also to take images, morphologic images, dimensions of this left main. I think both aspects are important if, of course, we decide to do something to the left main. So the first step is, do we have to do something? The second step is, let's decide how we are going to optimize these PCI. Agree?
Very good. Very good. I think it's pretty clear the flow of your decision making in this case. So just to summarize, what you have now at your disposal is a pressure wire.
Yeah.
So what you're going to do is to do a step-by-step functional assessment of the left main LAD lesion.
Yeah. Okay.
So we follow you.
Okay, so we are going to give you live scopy now because we have talked too much. You can go a bigger magnification. And we are in the RAO projection, and we are introducing the pressure wire. Well, you all know probably the pressure wires. There are many brands on the market, many vendors. I will not go into the details. That's not the principle is always the same, of course. And we are introducing the wire through a needle, really nothing special, routine clinical practice. And we can already check on the, could you show the Quantian, please? Could you show the pressure tracings? We can check that we have the signal. Doesn't mean that the signal is perfect, but this is the reason why at a certain point in time we will have to equalize. So we are going to go slowly but surely until the tip of the guiding. Here we come. And then it's a left main, so it's a little bit delicate. The first thing I will do to get rid of this is to pull back the needle. During many years, I have said, well, equalization can be done with a needle into the TUI, because if you use needles that are very small, this creates only a minimal error of 1 or 2 millimeters. But I think a minimal error is already too much, and I think we have to be, let's say, to have really excellent measurements. We're going to check while Gabor, who joins me now at the table, we are going to check whether we are still in the left main. We are just in front of the left main. That's good. And I would like already, you know what, we are going to disconnect the wire. I would like to show a small detail, really something which happens during a diagnostic catheterization. Look now at the pressure tracing, the red tracing, which is the pressure tracing that you would have through a diagnostic catheter also. And I'm going now to inject a little bit of contrast. Look, I will even film that. Okay, you see, contrast, I don't lie. And look at the pressure tracing. Look at the pressure tracing. What happens there? It's simply that the contrast is hyperemic. You increase the flow, including the flow over the left main, but the tip of the guiding is a little bit in the left main, obstructing partially the left main, which is not a problem at all when we are at rest, but as soon as we increase the flow, you have a change in the morphology of this red signal. So this has nothing to do with FFR and pressure measurements. This is just basic physiology, but this is already the signature of a left main ostial stenosis. Okay, so it's we're going to continue there, and you can connect the wire without destroying this wire, preferably. Okay, so you see on the pressure tracings that the green signal is reconnected, and I would say almost unfortunately they are very well superimposed. And the first step for every type of pressure measurements is to equalize. Now the very place to equalize, Eddie, the very place to equalize is there. So I will film it. It is with the sensor just next to the pressure, to the exit of the guiding. The goal of the equalization is to have the two systems speak the same language, so to speak. Okay, so this is the place where we are going to equalize. Now the question which comes back time and again is it needed to pull back everything in the aorta when we have a proximal left main stenosis? I will tell you, and I will even demonstrate that this is not the case. We can equalize at this place even if we know that there is some let's say problem at the level of the ostium. The problem is that we have to be very careful with this. Look, I'm going to engage the guiding a little bit in the left main, and you see the morphology which changes a little bit. But even there, even if the morphology is a little bit different, not when we have a complete wedging, of course, you can equalize. Okay, so there is no reason to make it complicated. The only thing which is important when you equalize is to make sure that the two sensors are at the same position and speak the same language. So we are going to push on the equalization button. I will keep my foot on the scopy. Clack, clack. And here we make sure that the PDPA ratio is equal to 1. It's not very spectacular because it was already the case to start with, but just to demonstrate that where we have to equalize. The next step is, of course, to go in the distal part of the vessel, and maybe Gabor.
Bernard, perhaps while you are positioning the wire, one of the colleagues is asking why not to do the equalization back into the aorta since the disease starts from the ostium. Any feedback on this?
Yeah, okay. What is really important is to put the sensor of the wire exactly at the tip of the guiding catheter. So if the guiding catheter is in the lesion, well, the sensor will be in the lesion too. They have to be exactly at the same position. Okay, that is what counts. We can do it in the aorta, but you can understand that going back in the aorta will complicate the case because we have to come back with the guiding in the ostium and so on and so forth. Okay, so
So actually what you mentioned, that what should be avoided, that your guiding is still in the aorta, but the wire is already in the left main, and there is an ostial lesion in between, then
That's
this
it.
equalization is not valid.
That's it. Okay, so you can give me a little bit of contrast, just to make sure we are going in the right direction, which is not at all the case. De LED, Katja, kunt je even rijden? Is somewhere here. We're going to manipulate the wire test in the distal part, because the next step, laat me de wire zien, will be to try to demonstrate a pullback. And I'm sorry if all these things are known and very well known, but probably there are some colleagues who have not too much experience. And all these nitty-gritties are extremely important for pressure measurements. And this is, of course, completely independent of the type of pressure wire. Okay, let's have a look to where we are. I will decrease the magnification even twice. Give us a good shot. Yeah, okay. So we are in the distal part of the LED. For some reason, the tip of the wire is in a small branch, but really this does not matter at all. That's not the big problem. By the way, look, we have already an information which is key. Gabor just injected, 5 cc of contrast, and we have seen briefly a hyperemic response with a PDPA ratio of how much?
Yeah, it was 0.75.
0.75, okay, even lower, I think. Okay, anyhow. So, now we are going to induce real hyperemia. We could, of course, say, well, why not just to use the PDPA at rest? In this case, I think it wouldn't be a problem, by the way, or use a non-hyperemic pressure ratios. You know that there are several on the market now. There is, of course, IFR, which is around since a couple of years, but also DPR, RFR, DPF. Okay, you will read a lot in the literature in the next coming month about this. And we are going to inject papaverine.
Here, may I just ask, is there anything what the colleagues should be careful with if they want to induce hyperemia with papaverine?
Yes, there is one detail. You are absolutely right, Gabor. There is one detail, and this is what I'm taking care of right now, is to flush the whole system with saline. So I flushed it with saline, and look what happened with the pressures. They go down again. Whatever you inject in the coronary artery, especially when there is a little bit contrast, but also saline induces hyperemia. But the lesson is, if you use papaverine, which is very convenient, it can be given intracoronarily, please be careful, flush all the lines with saline. So it's not a big, it's not rocket science, but it's important. Then we are going to demonstrate also something. I will start with the guiding well engaged in the left main. Look, you see the pressure tracings which are changing there? The morphology? This is something you should recognize immediately. The pressure tracings, the morphology has changed. And at this position, I will inject the vasodilator. So 1, 2, 3. I will inject 2 or 3 cc of this solution, which is approximately 12 to 15. And then I will disengage the guiding. Look what happened. Look what will happen. And to disengage the guiding, I will simply push. Did you see that? I will simply push on the wire. I barely touched the guiding. Look, 0.58. And you have a nice steady state which will last for almost 1 minute. Okay, so 1 minute lasts long in the cath lab. But again, this is just for the sake of the demonstration that I wait. But oh, we didn't record, sorry.
But I think this was a very important thing what you mentioned, and I think this is something what should all the colleagues remember from this case. If they use an intracoronary agent to measure FFR in case of left main, then the guiding should be engaged during flushing, but disengaged during measuring. If it's followed, then we avoid all the kind of pitfalls.
Yeah. But this maneuver is extremely simple. Huh? It's again, we are going slowly to demonstrate the points, but there is nothing very special. And you see that it lasts really long, a little bit longer than I would have thought, to be honest. And we will, yeah, now it's coming back. It's already 1 minute, almost 1 minute. But this is simply the proof that even if you use an intracoronary agent, it is possible to do a nice pullback. And this is what we are going to demonstrate now. We're going to wait another 30 seconds to let the PD recover its baseline value, which is happening now. Okay? And now, Gabor, we will not forget to push on the button to record.
Yes.
Okay, good. Okay, so we are almost back to baseline, and the guiding is still in the aorta. You see that at the morphology of the tracing, and we are going to do that again. Huh? Again, we engage a little bit the guiding. There's no problem to do that. You immediately see the difference between the PD and the PA decreasing a little bit because you impede the flow. And we are going to push on rec. So we are going to record for you. Okay. And now we are going to give the papaverine again into AD. So that's it. There we go. I push the guiding a little bit just to disengage the guiding. And again, we will fall down at the exact same value, 0.6667. You can do that 10 times after each other. Vasodilation of the microcirculation is one of the most reproducible phenomenon in the body. Now, let's put a marker on the pullback. You can put a marker and I will pull back. And you will follow on the screen what happens with one eye on the angio, the fluoroscopy, and the other eye on the PD, on the pressures. Look, we are approaching the middle AD. Nothing happened. Nothing happened. Nothing happened. We just passed the middle AD, and you see that there is a first jump. Yeah, you can put a marker. And now we are going to go slowly but surely. We are still hyperemic. We know it from the previous injection. And look what happened now. Well, theoretically at least. There we go. And we are back exactly to 1. So this is a pullback from the distal LAD to the aorta, actually. Coming back to 1. We are going to stop where we see better the distribution of the physiology along the vessel. So you have from left to right the rest, then the interruption of the red signal for the injection of papaverine, the increase in the gradient, so the PDPA, a nice steady state, and then the first marker where we started to pull back. And you see that between the distal part of the LAD until the mid, proximal to mid, nothing happens. It means that the conductance of whole this segment is strictly normal. Then we have a first jump, and the second jump is located. We have seen that just at the level of the left main. Again, this is not, well, this is classical. This is nothing new, but I think it is important to see it. And another detail, I'm sorry to be too talkative, another detail is this recording is what I could call a nice, perfect recording, which means first the pressure gradient at rest without doing anything, then during 10 beats, 12 beats, then you inject the adenosine or the papaverine or whatever, and then the recording, and then back to the baseline. Good.
Bernard, can I interrupt you guys? I know that the case has become very interesting. There are a number of questions that I think it would be good at this stage to address. Perhaps while Bernard is working, Gabor can help as well. So, of course, the first obvious question is if resting PDPA is less than 0.8, is there any need for the administration of a hyperemic agent? I think you alluded to that. I don't know if you want to further elaborate on this.
Well, my comment would be on that, that if the resting gradient or if the contrast gradient is already below 0.80, then there is no question that the lesion is significant. However, if we want to assess our result after doing PCI, then we need a good positive reference from the beginning. Therefore, I would always recommend to perform FFR measurement at the beginning and then FFR afterwards. So then in this way, we have a clear view where we started and where we finished the procedure.
But then there is also a question about crosstalk between lesions. While measuring FFR, one of the colleagues is alluding IFR instead. I don't know if you have a point on this.
Sorry, could you repeat?
While doing pullback, hyperemic pullback into serial stenosis, in this case left main and mid LAD, crosstalk between the two lesions, hyperemic better than resting, resting better than hyperemic. What is your opinion on that?
Well, the crosstalk, when we say crosstalk on between the lesion, very shortly, I would say the distal lesion influences the proximal lesion. Okay, so that's something we have to keep in mind. Second part of the question, is hyperemia better than resting gradient? Of course it is, because the dynamic range, the distance between the PD and the PA will be better, and then it will be much easier to see the differences. And when you look at the tracing, it's a pity we don't have the tracings there on the screen.
Yeah, now
And there you go.
You see very well, look at the diastolic part of the phasic tracing. You see the step up very, very well. Tack, one in the middle, and then to the left, to the right, a second one.
Bernard, hold on this tracing, because one of the questions is related now to the PCI strategy.
Exactly.
Looking at these two step up, one of the colleagues asks, would you stent LAD first or left main first, or what is your strategy?
Well, based on this data, we can make, of course, very complicated calculations from the, let's say, the contribution of each lesion to the total fractional flow reserve. We never do that. We never did that. We validated that 20 years ago, but we never applied that. We have to be pragmatic. Here, the biggest jump is clearly in the left main, And then, since it is the left main, since the guiding will seat probably in the stent, it will be no problem to treat the LAD if needed. So that is my strategy. First left main and then the LAD.
Okay. Can I ask you what will be your next step now?
Well, I alluded to the fact that having the dimensions of the left main is important, because we will have to stent this left main LAD, and we have to know more or less how this left main looks. So we have several possibilities. Either we do QCA of the left main, we all know it's difficult. Either we do IVUS, that's probably still for the left main a good choice. And either we do OCT. Now, IVUS is something which almost disappeared in this lab. And so we use preferentially OCT, which is not completely classical for a left main, but maybe you can comment on that.
Well, I agree with you. It's a tubular left main. The disease really starts from the ostium. I anticipate that clearance will be somewhat suboptimal in this case, but we can give it a try. If we have good coaxiality of the guiding with the left main, sometimes we can obtain good images, but I think we have to try and see.
Well, you know, Emanuele, what I want to know in this left main is the size, period. A little bit, of course, whether there are calcification, but I think this is not a very calcified left main. I would like also to see the ostium of the circumflex and the size of the LAD. But what I would like to know is have an idea of the left, of the diameter of the left main. And so whether we see the ostium is not that important. I will even engage the guiding quite well, and you can monitor that on the basis of the pressure. We need the big syringe. And we are almost ready to do OCT. You see that we have introduced the dragonfly in the over the pressure wire, by the way.
Inform me when you're ready, because we need to make a couple of...
Yeah, you know, I will first put it more distal and then over the dragonfly. While pulling back the whole system, I will pull it back. And look at the pressures that disappeared again on your screen. But this is very important. Keep the pressures always on the screen. Okay, we are ready.
Give me a second, Bernard.
We are wedging a little bit, not a problem. We just have to disengage.
There is good purging here, so I do auto calibration. Tell me when you're ready. I will put on enable pullback.
Yes, I will film.
Okay, you can inject when you want.
Yes. Not sure it will be perfect, but again, it is a left main, and this is something we know is a little bit more difficult.
And pressure is back to.
Yeah, but I
Yep.
pull it back. I don't know whether we see something.
Yeah, I think it was.
It's actually
quite
not
good.
too bad, Bernard, despite the fact that the guiding was not selectively engaged, or at least you did the best you could.
No, it was selected.
It was selective because on this side I can't see, but the quality of the clearance, I would say it's not too bad actually. I let it go till the end. Let's try now to localize where this is the stent in the LED. We still see the stent struts, and this will be more or less your landing zone. There is some intimal bifurcation. While we go back, I'm trying to identify the ostium of the circumflex.
I'm going to move it back.
Let me
just tweede wire. Tweede wire.
So this is the ostium of the circumflex here. So your first question was about the landing zone of your stent, right?
Yes. And the size of the left main, actually the distal left main.
So
yeah. What is that?
So the size of the distal, the landing zone of the stent to proximal AD.
Well, no, Eddie. Eddie. Yeah.
Yeah. Okay.
But I think this is more or less a compromise in case of left main imaging.
Yes.
Either you have good quality and good flush,
Yes.
but then you don't see the ostium because then you have a well-engaged guide, right?
Yeah. This is back into the guiding, and this is actually the vision in the left main.
Yeah. So again, I'm a relatively simple guy with OCT. I just need the diameter of the distal part of the left main, the body of the left main.
So I can tell you this previous stent, since we don't have this information, this treatment occurred, as we said, back in Greece. The distal stent was a 3 millimeter stent. So your landing zone will be 3. At least the stent was 3 in the proximal area.
Mm-hmm.
What was the next information you needed?
The distal left main, if possible.
The distal left main. So this is the distal left main. Something like this.
No.
This is the distal left main. So this is, yeah, that's more or less the lumen contour. We have a 2.26 of 4 millimeter of. So we have 4 square millimeter of minimal lumen area in the left main, Bernard, which is far below the anatomic threshold for significance. So this perfectly matches with your measurement. And
even though the tightest part is certainly the ostium that we don't see though. So this is the circumflex. I will put that behind the drapes, and you can give us a 3.0 millimeter balloon. Compliant.
Well, difficult to measure this one. It's all diseased.
Okay, and now we are starting a regular PCI actually.
What is your strategy for the PCI? Based on what we have seen.
Yeah, we have seen a tight left main, it's a body left main. The LED looks more or less okay, a little bit smallish, but it's diffusely diseased. And the circumflex, the ostium, doesn't look to be too tight, 15 there. So we are going to go for a one-stent strategy with crossover from the ostial left main to the stent, of course. We have to land in the stent, that's important. And I'm not going to make it very difficult with a lot of second stent strategies. But of course, I'm going to protect the circumflex, if you agree. You agree with it, Gabor? Okay, and then of course we will have to, let's say, to decide to fine-tune the PCI while doing the PCI. It's impossible to foresee on the forehand every single step that we're going to undertake. We have to do that as much as possible in PCI, but cannot foresee everything. Okay, so first step, which is important, is now to disengage the guiding and to see where the ostium starts, and to measure the length of this the segment that we have to stent. Wait a minute, I'm going to put biggest magnification. Yes. Okay. Okay, the balloon is 15 millimeter long, so we know already that this is a little bit too short. You agree?
Yeah, I think distally we have definitely a few millimeters, and proximally we are more or less fine, right?
Yes, but it would be more comfortable to have a bit longer. Okay, we're going to inflate. Now the first step is to enlarge them and to try to see better and better. Wow. Okay.
14.
Meneer,
16.
Eddie, could you come to the patient just to tell them? Oh, I didn't feel that's fine. It's not a problem. Okay, we're going to also dilate the ostium. Yes, I will film it with a bit contrast.
14.
Look, this is only a 3 millimeter, and it looks like a 3.5. So, because all the vessels are so small.
So Bernard, just to provide you a wrap-up of the OCT information, the stent that was implanted was a 3 millimeter. Proximal ostial LED is almost 3.5 millimeter. The left main is completely diseased. We really didn't find any segment where we could visualize the media. And the MLA is less than 5 millimeter there. So it's really a tight left main disease.
Yeah. So we can estimate the size of the left main that we will have to get by the law of Finet. And Eddie was so kind to do QCA before the procedure of the circumflex, which was 1.9 millimeter, keep this in mind, plus the 3.5, let's say 2.3.5, that is 5.5. Now you have to multiply this value by 0.67, let's say 2/3 of 3.5, 36 is 24. Okay, so we need, let's have a look to the angio again, because I'm making wrong calculations, I think. Okay, I will do a good angio again, because this was a little bit sloppy. Okay. That's not too bad. The left main increased already, especially the proximal part.
Yeah.
I think I will pre-dilate again with a 3.5 to prepare the left main a little bit better. Eddie, geef me een 3.5. Nee, geef een 20. We'll take a 20 and we'll let him a little bit outside the vessel. This also will allow us to measure the length a little bit better.
So you said 3.5 ostial LED, the circumflex will be 2.5, 275 more or less?
Well, the circumflex was on QCA 2, a little bit less even, which is difficult to believe, but...
we are 5.5 to 6, let's say.
Yeah.
If we take 2/3 of this, we are around 375, 4 millimeter, more or less.
A little bit less,
yeah.
But again, this depends on the lumen, which is diseased. And so we have to take into account that this is the minimum size that we have to get. 3.6, as you mentioned. With a 3.5, we can almost reach 4, so we are going to give it a try. And again, we will use the balloon also to measure. It's a measure and the length. Is that the best quality of scopy? Yeah, here we are in the. It's not yet long enough, huh?
No, I think a bit longer than 20 would be quite comfortable to position, right?
We'll need a 24. So.
Yeah.
Okay, you can inflate. Patient has no
10,
major chest pain. He feels something, but no major chest pain. I like to film this always with a little bit contrast. Okay, to make sure it is closed, hermetically closed. the pressure remains very stable, the central pressure.
While you perform that, Bernard, I will try to address some of the question here. Can you show again the OCT scan? Ostium of the circle is not clear. Actually, it's true, it's not clear. So I can assure you that it was so diseased, the left main, that the ostium of the circumflex was not really clear. So even if I show it again, we won't learn much out of it. Is it necessary to make pre-dilatation rather than direct stenting? I would say yes.
Oh, yeah.
I would always say yes, even if you have OCT guidance in this case, and you can be reassured by the quality of the tissue that you don't have calcified ring. I think it is always good practice to prepare carefully your plaque in order to have an optimal stent implantation. That's my position. I don't know your opinion, Bernard, on this.
No, I fully agree, especially in left main. I think we came back a little bit from the direct stenting in general, except in some situations, but for the left main, really, it's almost a must. And it's always also a sizing tool, which is so useful. It's so simple. Why to miss this opportunity? Okay, so we have dilated with a 20 millimeter 3.5 in diameter. We are again going to take a good angio. Katja, goed centreren. Yeah.
It's getting better and better.
It's getting better. We are going to, so that's after 3.5. I'm almost certain that we are getting 4.5 in the left main at the end. Okay, Eddie, give us a 3.5 stent, 26 length, whatever you find there.
Yeah, I think what is important that, as Emanuele said, he could reliably measure the landing zone diameter, which was around 3.5, right?
3.5, correct, yeah.
So it already gives the answers, what is the diameter of stent, what we have to take.
Mm-hmm. Mm-hmm. And there is another point which is important at this stage. Look at the pressure again. Simple pressure, which is there on the screen. Yes, and look, I'm going to give a little bit contrast. So the patient will be hyperemic for a couple of seconds. Look what happens, ventricularization. So we know that the ostium is still way too small. You will agree that this is the poor man's IVUS. Huh? Okay.
While waiting for the stent, Bernard, can self-opposing stent be also an option in this case, Bernard and Gabor?
What?
Self-opposing stent, you know, the self-dilating, self-expanding stent, yeah.
I have no experience in the left main with these kind of stents. Onyx, yeah, that's good, perfect. Thank you, Eddie. Hij heeft pijn op de borst. Yeah. Okay, so sorry, Emanuele, we left you unanswered.
No problem.
But I have no experience. Why would you think it is better to have
self-expanding? It would be an option when you have a very large mismatch between the size of the left main with the size of the daughter vessel. That could be perhaps the setting where I would consider self-expanding stent.
Well, I don't have much experience with the self-expandable.
But not in this specific
case. With
the
size, absolutely.
So it is a 3.5 onyx stent that we are placing, 26. So you see we took it a little bit comfortable there. But I think we underestimate the length of the left main because in one projection early on, it was much longer than I had thought, and we have to reach the gain. So let's take several shots here, Katja. One in this projection, because we have what is important is to position the ostium. Okay, we have to do it again. Yeah. Okay, that's way too proximal.
Would it be useful here in Tintin? Yeah.
LAO. Yeah. Okay, that's for the proximal part. You're ready? There we go. That's still, we are going to, yeah, we should not miss the ostium because we know that this was the culprit. But on the other hand, I hate these struts protruding in the aorta. So, ga eens in 30-30. 30-30. LAO 30, ja. Nee, craniaal. Oh, eigenlijk. Ja, zo. Zo. Ja. Ja, dat is perfect. Oké, test a little bit. We are going to approach the guiding. Yeah. No, we are way too deep. It's not that easy. Huh? We are hesitating. Okay, again. No. Let's reason theoretically. What is the best projection for this kind of position? It means the left main proximal LED. Kunt je ook gaan in de LAO craniaal. I think we are almost there, but
This was also the proposal of a couple of colleagues to take an LAO cranial.
LAO craniaal. Yeah. Yeah, but I think the
More cranial?
proximal part is okay, but more cranial and more fast. Yeah, so heel craniaal. Yeah. Yeah.
Yeah.
It's not too bad, huh?
That's not too bad, no. Yeah, still okay. There will be some part protruding, but okay. No problem. Okay, the battery is yeah. So I'm going to film.
Yeah.
Wait a minute,
Okay.
just to inject. Yes, inflate. Yeah, I think it's okay. Yeah, but it's still way too small, huh? Okay.
Dus oké. Je mocht hem geven een andere halve sessie.
Eddie, je mocht een korte 4 geven. 12 mm 4. Nee. We're going to do the pot already now to facilitate the recovering the side branch. You agree with that? Or
Yes, I think what I mean, it's trivial, but it's important to mention that what should be very careful at this moment not to try to engage the guiding, because one wire is behind the stent in the circ. So any attempt to engage the guiding will just crush the stent.
Yeah.
So in this moment, it's important to keep the guiding outside, floating in the aorta.
4 mm ballon. Korte 4, ja, rond 10 of 12.
12.
12.
4. Nee, een normale.
Gewone.
Okay, so yeah, this comment by Gabor is very important, and I made a mistake a couple of times in the beginning, and because you forget that one wire is out to stand, and yes, test, and the other one is okay. I think it is more or less okay. Let's come back to the RAO with caudal, Katja, so that we can see the ostium of the circumflex a little bit better. Patient has ST elevation, which were partially present in the beginning, but maybe a little bit more now. I hope
Niet compleet.
Een semi-compliant, een normale ballon.
Dan is 4,8. Ja. 4,8.
Je hebt geen andere? Geef de 8 dan. Ja. Okay. So we are going to post-dilate now the left main with the so-called pot. We have a 4 mm balloon, and I will take a semi-compliant 4 mm. There is no calcium, so the goal is to reach actually probably 5 mm here, progressively. And we only have 8 in length. We do not have 12 or 15 anymore, which would have been more convenient, but that's not a problem at all. We will fix this. You can stay in this projection, Katja. Oh, I made a kink in the wire. Not good. And to do the pot, could you explain that? We have to put the marker where again?
Yes, exactly. So the pot is performed properly if you are not going over the side branch, right? Because actually your goal, you have selected the stent according to the distal main branch diameter. And now your goal is nothing else to
okay, good.
upsize proximal main branch size.
So what I remember is that we have to put the marker just in the middle of the side branch, of the lumen of the side branch. You agree with that or not?
Absolutely.
Okay, go. the guiding is, well, the left main is not that big. I will pull back the
14, 16.
16. Okay, so this is now serious stuff, huh? 4 millimeter to 16. We're almost at 4.5 or 4.25. We will do also the ostium because we know the ostium is covered. Yes, go. And then we'll have a look again. And again, you are right, we do not have to try to go into the left main. But on the other hand, personally, I like to keep the jailed wire because it's a very good anchoring device. Agree?
Exactly.
Oh.
So.
Okay, let's have a look. Voilà. Gaat het, meneer? Ja, go. Oh, sorry. It's good, but it's not yet very big. Eh? So what I would do, I think personally the part of the stent which is in the LED is big enough. You agree with that, or do
the
you
LED
want
looks big
post-dilatation?
enough. It will be checked by the OCT at the end anyhow.
Yeah, but I would like to go even further. Eddie, geef eens een 4,5. You agree with that, or?
Yeah, I think. I mean, it's an 80 kilogram male patient.
It's a male patient. Yeah.
So this left main will be
12.
4.5, even 5. But we will check on the OCT at the end.
Yeah.
So let me ask to the colleagues whether they do agree to take at this stage a bigger balloon to do POT. So just for the sake of your information, we have post-dilated this stent with a 4 semi-compliant balloon. What Bernard is asking is a 4.5 millimeter balloon to perform a POT. It's okay. With the bigger balloon, do you agree? If you agree, please push on the button.
Yeah, exactly the same.
So while the colleagues are replying, I think it's a good choice, Bernard, to optimize this stent dilation. Will you perform afterward kissing balloon in this case?
Not sure it's needed, but okay. I think it's politically correct to do so and to say that we grant access to the circumflex, but actually I never believed that. But
so most of the colleagues agree with you that we should dilate even further this stent.
Yeah, that's one thing. Yes.
It looks good, no?
Yeah, okay, cool.
And while you perform this additional POT, I will take the opportunity to ask whether the colleagues would agree to do kissing balloon after this. So if you agree with kissing balloon, please both thumb up.
Wait a minute. I will have that's better position. Okay, go. Go to 20, even 24. It's a so-called non-compliant balloon, and actually this is not really useful here to have a non-compliant balloon because
there's no sign of life.
Go really as high as possible. I will find, yes, I always finish with the inflation in the ostium. Yes, go. Same, that's fine. Pressure on. Okay, so that's fine. So let's have a look now. And again, don't forget we have a wire jail, so no too deep intubation, especially when pulling back the balloon.
So there are a number of technical questions. I want to reassure the colleagues we will have time also at the end of the case to address all of them. No worries.
still on time or what?
Yeah.
Okay. So one of the colleagues asked whether it's not the time to take out the wire of the circuit, but you already explained that this jailed wire offers very good anchorage of
Yeah,
your
but it's a
guiding
good
catheter.
question. It's a good question because it's always easier to have only one wire, but you know, as long as it's not finished, you have to be careful. Yeah, by definition, it is also a very sub-selective shot, precisely because this other wire. By the way, it's the first time that I see the mid-LED lesion that well.
Yeah.
And, you know, I will take this moment, if you don't mind, to have a quick look with physiology. And if this is positive, we will stand that. If it is not, we will leave it. But it's better to do the OCT at the very end, if you agree, Emanuele.
Okay.
Look, the pressure wire, despite all the manipulation, is still alive and kicking. And yes, come back. And we are going to see whether it's in a good shape to be equalized again. So here already we might say, well, is this drift or what? And you can see already that this is probably not a drift because the morphology of the green signal is a little bit different. So I will prudently pull it back. I say prudently because the tip has been damaged. And you see the step. Here we are in the proximal part of the LED. And it's not exactly according to the rules, but I do not expect any pressure drop across the stent we just placed. So I will equalize here. So don't tell it to the purists, but I equalize there simply because I do not want to recross the lesion with a wire which has been damaged. Before doing this, we are going to flush the guiding catheter, and you see that there has been some small drift, not a catastrophe. Yes. Okay, so we still have a couple of centimeters. Yeah, you see that here we are really in the very proximal LED, so it's not possible that there might be a very big gradient, and we are going to go back in the distal LED from here. Okay, so there we are back in business. Papa Verena, yes, you see already the gradient, huh? This is addressed. We didn't do anything except moving the wire. Papa Vereen? Nee. So this will be a quick fix, I think. And you see that here we have a PDPA ratio of 0.84. Guessing, I would say the IFR or the RFR or the DPR, they're all equal. They should be around 0.82, 81. So definitely positive. So at rest, we can already have some appreciation of what happens, but we have to realize that we are not at rest at all. We are, after many inflations, we are in a persistent hyperemic state. So we are going to flush the lines, no contrast in the lines. You see, I flushed a little bit contrast and we are back to 0.74. So you see, it's not trivial, this lesion in the distal LED. Okay, good. And now we are going to rec. So we start with PDPA value of 0.85 and look what will happen. Rustig blijven liggen, hè? We flush with saline, as I mentioned. Sorry for all these artifacts. What? Yeah, it's clearly positive.
Quite depressing.
By the way, also very reassuring, the red signal remains normal, which means that probably the left main ostium is normal. You are going to say, yeah, but the guiding is maintained outside the left main. Yes, but probably it's still a little bit in left main. So it's slightly positive, so we have to go. Okay?
Okay.
You agree?
Yes, sure.
So give me one of the balloon that we have used, please. And look here, I'm happy to have these anchoring. Om het even te welken, maar een 3.0. Hebt je nog pijn op de borst? Ja, dat kan.
Which one is this?
It's a what?
315.
Okay, but we have to take a good projection to see exactly where we have to go. And actually, it is probably kind of stenosis just at the edge, the distal edge of the previous stent. No?
Yes, it's a distal edge.
So perhaps, Bernard, when you're doing that, I'm addressing quickly a couple of questions. Why not adenosine? In this case, Bernard preferred papaverine as it was convenient intracoronary injection of vasodilatory drug, and it could also perform pullback, something that with IC adenosine would be more difficult. We should have switched to IV. So that is quickly answered. And then is it good to make equalization of the proxial AD just to evaluate the medial AD lesion? I think you explained here that you did not expect much of gradient across the stent in the left main. But from a theoretical point of view, we should have done the equalization with the pressure sensor back to the tip of the guiding catheter.
It's a very good question. What I showed was not really according to the rules.
Okay, we let you treat the middle AD. Then I take other question. In osteoangioplasty, do you usually try to leave around
18?
So do you try to leave how many millimeters of the proximal part of stent protruded to the aorta? Well, actually, this is wishful thinking to imagine that you can decide to leave 2-3 millimeters out of the osteoma. You try to leave the minimum amount of metal possible, but there will be some millimeter of metal that will protrude out of the osteoma. There's something you cannot really control.
What I'm doing here, it's also very crude, but the balloon has completely lost its profile, has been used twice. Yes, and I try to pass the proximal left main. I see it passes, but I feel some resistance, so we have to be careful with the stent. So we are going to put a Onyx 3.018 because we know the other stent was a 3.0. It's just an edge restenosis. Sounds logical to do so. Okay, excuse. Now, to be honest, I still expect at the end of the procedure, even after this stenting, a quite marked pressure gradient during hyperemia. Probably not at rest, but during hyperemia. And this will probably be related. Well, I hope it's not the case, but if it is the case, it will be probably related to the diffuse disease of this vessel. Probably much more than to the stented segment itself. Oops. Do you see what happened? Good. Okay, now we have to change a little bit the strategy. Okay, no, it happened. I was not coaxial. No. Just this view is good. Yes, go. Okay, there is a nice dissection there in the roof. I think we are touching the previous stent. Yes, go. You agree? More or less. Actually, the reason why the stent came back a little bit was simply due to the fact that I was not coaxial. So it was... Ja, nu hebt u terugpijn, dat kan. Keep it inflated. And go to... Yeah, it's okay.
I think what will be important at the end to post-dilate the left main once more, because we have manipulated the guiding around, crossing with stent, so close the procedure with the left main.
Geef de 4,5 terug. That's true. It's a very good point. Yes, stop. Emmanuel, you are...
Yep, following.
Pleased. Yeah. Oh, you're right, Gabor. That's a good point.
Would you mind, Gabor, to repeat for the interest of the colleagues what you just suggested to Bernard?
So that after treating this middle idea and at the end of the procedure, I think it's very important to perform the plot once more to optimize the result in the left main, because you manipulated with the second stent there, with the guiding there, and so on. So there might be some strut compression, stent compression, deformation. So we should correct all these issues at the very end.
So what you are now doing is going back with a 4.5 millimeter balloon, the one that we used before, to optimize again the ostial part of the stent.
Do you think it makes sense to remove now the side branch wire if we think that we don't want to treat it?
No, because this balloon has completely lost its profile, and I'm not sure it will be that easy to...
I mean before inflating. So when you are already in place, but before inflating, because even pulling out the jailed wire can stretch the strut somewhat.
Yes, and even more when pulling back the balloon, you can advance the guiding. It's... you see, it's even much harder than to get...
Perhaps we can take a new balloon.
Yeah, take a new balloon, please.
Eddie, can we have a new 4.5 millimeter balloon? Yeah, 4.5. 4,5.
Yeah, this balloon is completely gone. But, okay, nevertheless, we have to do that. And then afterwards, I would suggest to do the pressure measurements, OCT. Hey, come.
It's okay.
Yeah, 15 is ook goed. It's even better. The ST changes are gone now. That's always nice to see. It was difficult to understand why he maintains ST elevations.
So ST elevation is gone. That's a good feedback, because one of the colleagues was asking whether this might have been due to the subtotal occlusion of the first diagonal branch.
Yeah, that's
difficult to answer this, but it's reassuring that the ST elevation is gone.
I think the wire came back because...
So again, why not removing circumflex wire before mid-LED PCI? But I think I agree with Bernard that this wire in the circ is offering a beautiful anchorage, so it could swiftly push the stent up to the mid-LED without problem. So that could be a good rationale for keeping this wire.
Okay, well, here we are facing a small technical problem, which is interesting. It's namely that we cannot advance the balloon into the wire, into the stent, and it's difficult to determine why this is the case. Of course, the support of the pressure wire is not the best one we can dream of, but I wonder whether we haven't made a buckle. No. We have to be more careful, to be more coaxial.
Now I think that removing the circ wire could help you to make it more coaxial, because
you're right. I'm going to try a last time, and then we will. Yeah.
Perhaps we can look also in other projections just to make sure.
Okay. Katja. Okay. So. Oh yeah. Huh. Well, not completely. Not completely. It's not really very well engaged. Ah, that's better. Okay, so test. Okay, we have to come back there. Yes, go. So again, here we are dealing with a 4.5, still partially in the guiding. That's not a problem at all. It is expelled. It expels the guiding post. Yeah, okay. I think this trick of Gabor, well, the trick, this maneuver is important, because now theoretically we could engage the stent. I'm not going to push because probably there are struts which are in the aorta, so we can destroy them. Could you give it a good, yeah, we are very well engaged now. Okay, Katja, let's take 2-3 good shots. How much contrast did we use? 260. Nay? Oh, look at the diameter of this circumflex, which appears to be ridiculously small as compared to the left main. I think it is okay. You agree?
Yeah, I think I would not touch this circ,
No.
especially considering the history of this section in the right, and that is
I
diffuse
don't like that.
vulnerable vessels.
Okay. No, but that's add the torque. No, we don't need it. We are just going to do one, I would say, documentary shot, hyperemic run. Yeah, I know, but we are flushing with saline. The reason we have to flush with saline is that when you don't do that, the mix of papaverine and saline is pro-arrhythmogenic. And actually, papaverine has a kind of bad reputation because it might induce torsade de pointe. Okay, we are going to record. Is it recording?
Yes.
Okay, so we are ready to inject the 12 to 16 milligram of papaverine again and again. 1, 2, 3. There we go. And I expect still a value of 0.85 or something like that.
Yeah.
Oh, it's just 0.85. I wonder why I still measure it. So this is sometimes really disappointing, but this is really, we have to accept that these vessels are diffusely diseased and that the epicardial resistance is abnormal and will remain abnormal. Can even put 2 other stents, it will remain like this.
Still, Bernard, I think you can make a point that we started from 0.5 more or less in the beginning, so we had some gain from this revascularization, moving up to 0.84.
Okay, OCT.
So, in the interest of time, can you share with us what you intend to do now? OCT and stop, or do you still intend to do kissing or other things?
No.
Okay.
If you agree, I would just do the final OCT, and it's important. This OCT is important because we are at the verge of the Illumin 4 trial, where really OCT will be used to guide stent implantation. What is it? To guide stent implantation and to guide post-dilatation, apposition, and all these things. So we will have to be used to go back after the OCT runs with other balloons and maybe other stents even to optimize the treatment, because this is really the potential of OCT, and the goal of the Illumin 4 is really to show the equivalence or the superiority even of OCT as compared to the angio guidance. Okay, you can advance a bit. Thank you.
Perhaps once we are in position, Gabor, if you can purge before we start the rotation here.
Okay, so I have a. You know that the OCT catheters have a
20 cc?
Very short monorail path, and I have a little bit of problem to engage the left main with the OCT, but I'm still using the pressure wire that I used in the very beginning, and you see that we are jumping. Will try to engage a little bit better. Could you follow here? Okay, there we go. Okay, so we needed a better support.
So you will position the intermediate marker where the lens is beyond the distal stent, right?
Yeah, and by the way, to have a good flush, I also need good intubation of the left main. So we have to be there, but on the other hand, we have to be prudent also, because we know that there is a stent there, and we know that some struts are protruding. Oké. Ja, we zijn bijna klaar, meneer. Oké. We are well selective. I will pull back a little bit more.
Let
Like
me
this.
check if
Okay.
the quality of the clearance is okay.
5 minuten. 5 minuten en we zijn klaar.
You don't need to purge. It's okay like this.
Oh,
Okay.
incredible.
So
Eddie.
are you ready?
Yes, we are.
So tell me when you want to start.
Okay, I will start now.
Okay, we have it all. Thank you very much.
Nice image.
So we'll start by showing the distal stent. We are now entering the distal stent, which is nicely circumferential. There is some degree of eccentricity here, but it is well opposed all the way through. It seems to be well opposed, the distal stent. In the interest of time, I will quickly go to the stent into the left main LAD. This is the landing zone of the stent in the left main LAD, which is again nicely opposed and circumferential.
Je mocht in LAO komen, veel craniaal om die diagonaaltechniek goed te zien.
So, what do you think of this stent? Yeah, in the rendered stent, it looks much better.
Okay.
So nicely.
Yeah. Oh, that's nice.
Yeah.
Seems to be nicely opposed all the way through. And also in terms of expansion, it is nicely expanded stent. Perhaps only this one, only the distal stent has still some degree of eccentricity that we could
now
improve.
in the longitudinal view, you see very nicely the tape, how the stent is made tapered.
No
to
edge
the
dissection. So Bernard, to summarize the OCT finding, we don't have edge dissection. That's the first information for you. The stents are well expanded. There is no stent malapposition on both sides. Only the distal stent perhaps has some degree of eccentricity, but I'm not sure you can improve it any further with additional balloon dilatation. So all in all, the results of the two stents is good.
Okay, so I think that we are going to close the case if you agree.
Yeah, actually, we could close the case from the cut lab and still have the time to address some of the questions we have. I just take the opportunity that you are here.
Yeah.
So let's go quickly to the first question, Gabor, since you are now free. One of the first colleagues asked by Finello, I think there was no doubt that this left main was seriously diseased, so probably there was no need to do imaging or function. This is, of course, a good comment, but I would say this comment pertains to the situations where colleagues just do not have at their disposal all these tools. So what is your practical advice here?
Yeah, so my practical consideration, of course, Finello is a very good tool to use for sizing. It can be a good tool for such cases, as you mentioned, if you don't have access to any of these techniques. But for instance, as I said at the beginning, understanding their functional importance in a patient after anterior MI, it's very difficult to define simply based on any morphological measure.
Okay, next question. Any reason for femoral access? Well, actually, there is no specific reason. If you like radial access, you do radial access. If you like femoral access, I would say use femoral access, whatever it is more convenient to you. Is it correct to do normalization or equalization depending on the console you have with guiding catheter engaged in left main by measuring FFR with guiding catheter disengaged, as we did before? So
yeah. That's an important question. Sorry to come back on this detail, but the only goal of the equalization is to make sure that the two systems speak the same language. So wherever you do it, it will be fine, as long as you do it carefully. But you should not, for example, equalize when the sensor is in the distal part of the vessel and the guiding in the proximal. That's of course not the right place.
Then a couple of questions pertaining the concern of using OCT in diseased left main where the ostium is also involved. I think indeed there is a consensus in that case that OCT might be not optimal when ostial left main disease is involved. And next is about IVUS. Do you think IVUS could be a better choice for left main evaluation?
Finito.
Well, in IVUS you don't need to take care about good flushing. The contrast volume what you use is less. But I think to do PCI optimization, so assess the stent after placing it, it goes much better and easier with OCT. So the end, use what you are familiar with. I think this could be the strongest suggestion from our side.
This is an interesting question here. What is the best technique to place left main at optimal position covering ostium with no much protrusion? Would a third wire in the aorta help? Have you tried this technique?
Exactly. This is something what we also plan to mention, that in some patients simply you cannot achieve a good projection where you can see the ostium. Then to placing a wire floating in the aorta, just to leave the radiopac marker of the third wire coming out from the guide floating in the aorta, it can really nicely mark the ostium of the left main.
Okay, that's another important point. Very quickly, there are still a lot of questions. Let's try to answer the most important one. Was the final FFR, what was the final FFR result? We missed it. It was 0.85. 85. So that one we saw it.
Ik moet even duwen.
Let me see. Left main disease was frequently an exclusion from randomized clinical trials. I think this pertains to the functional guidance, and so any opinion? We have registry data there.
We have registry data, and I think this is the strongest data what we have currently. But on the other hand, we have also no reason to think that FFR works differently in left main than in other settings.
Why not to use a 4 mm stent from the beginning instead of a 3.5 post-dilated to 4.5?
Well, it's a very important question, and it's very important to clarify that in case of bifurcations, you choose your stent according to the distal main branch size. Here the LAD was clearly 3.5, so in case we use 4 mm stent, it would be a bad choice, because then it oversizes the distal main branch, it compromises the side branch access. Voilà. So the right choice, as said, accordingly the size of the distal main branch, which was here 3.5 clearly.
And here there is a friend of Dr. Guayumi in the audience who asks, as my colleague Dr. Guayumi always teaches me, is that OCT is done for measuring. So I think you can measure left main for deciding the size of balloon for pot. Of course, we can always measure that. We know pros and cons, and we know that Giulio is an expert. So unfortunately, he's not with us today, and we are not as expert as he is. I think, Gabor, we are almost heading to an end. We shall perhaps wrap up and give some key messages. I see that Bernard is closing the access. Do you want to just wrap up?
So just to summarize what we did here today, we had a young patient with a history of anterior MI presenting with stable angina, having a clearly significant right coronary artery stenosis, which was treated during the previous procedure. And during this procedure, we were facing an ambiguous left main plus a moderate LAD lesion. We performed functional assessment, demonstrated how to apply functional assessment of the left main, and since it was significant, we demonstrated how to use OCT guidance to perform optimal PCI of the left main, and how to deal with downstream stenosis, how to understand the importance of downstream stenosis. Accordingly, I think
we have some key messages
that we managed to show you how to use FFR assessment as a tool to rule in or rule out ambiguous left mains for PCI, how to use FFR pullback curves to enable to identify the relative contribution of downstream stenosis, and to show how OCT allows accurate PCI guidance in terms of sizing and stent optimization. So I would like to thank the participation of you all, your contribution with all your answers and questions, the participation of the whole team here in us. And of course, thanks a lot for the generous support of Medtronic with unrestricted grant to support these webinars. And as before saying goodbye, I would like to remind you that we have this was the second module of a series, and the third module is just after the summer holidays. In early September, we will discuss decision-making in patients with complex left main disease together with Marco Nock and Christoph Naber. So thank you very much, and see you at one of our next webinars. Thank you for all you.